Hello, everybody. Thank you so much for doing the homework. There's one more coming at the end. We're going to talk about medical therapy now, and we might have to go just a few minutes into the lunchtime, and then we have a full hour for lunch, so it may be a little less time for lunch. Thank you so much for doing those surveys, whether you're here or online. This is now the official start of the program. So if you can all come in, I don't know if you can hear me in the other room. Thank you. We'll start on medical therapy of acromegaly. And thank you so much again to all of our sponsors. We've already talked about treatment goals, so I'm going to start with the medical therapies. And actually, I think you guys are know more than some of the endocrinologists about this and the different types because you've talked about them and thought about them or are taking them. And that includes the somatostatin receptor ligands, octreotide, lanreotide, and pasireotide, dopamine agonists, and the growth hormone receptor blocker, which we talked about yesterday as the one that blocks the growth hormone receptor and does not rely on what your tumor is doing and does not block tumor. Very few of you will be on cabergoline alone for acromegaly, but some of you are on it in combination therapies, or if you have very mild growth hormone excess, then cabergoline will work. You don't want to be on this drug if you have serious psychiatric problems or impulse control. And the choices of therapy you probably already know. There's a big variety for octreotide, the lowest dose 10, the middle dose 20, then 30 and 40 per month. And now we have an oral octreotide at anything from 20 to 40 twice a day. There's lanreotide, a close cousin to octreotide that is a long-acting shot, and the correlate doses of the 10, 20, and 30 are 60, 90, and 120. It's funny because when I give this talk to endocrinologists, they could not care less sometimes if they're treating diabetes about the minute details of the doses and the differences. They want, kind of the big picture because they have one patient with acromegaly. So I feel like you're all actually listening. And then for patients that don't respond to what we call the first generation somatostatin receptor ligands, which bind to those special receptors on the tumor that are somatostatin receptor 2 and a little bit of 5, the ones that are more somatostatin receptor 5 and trickier, tougher tumors, pasireotide will work on some of those. And so it has a little broader action, still working at the level of the somatostatin receptor, which is expressed on some tumors, not on other tumors. If you don't make a somatostatin receptor on your tumor, you're not going to respond to these. Overall, about 50% do respond. And sometimes when they do respond, tumors are actually held in check or shrink a little bit, which is a very nice extra benefit of these drugs. This type of drug doesn't only just treat the IGF-1, it treats the tumor. Side effects, you all know, it can be stomach and GI side effects early on. Gallstones can be a common problem. Sugars either up or low. And I don't have to tell this audience about injection site pain. Octreotide orally has been a new advance. Some of you have had the option to switch to this. You do have the option to switch to this if you're fairly well controlled on any of the other somatostatin receptor ligands, octreotide or lanreotide, and doing well, you can switch. And if you haven't already switched, it's something to consider if you are someone who thinks you can take a medication twice a day, and be a little bit careful about taking it an hour before, at least 1 hour before a meal, and waiting 2 hours afterward before you eat again. Overall, that will work very well, just like the injections of octreotide. It's the same molecule, and it will control IGF-1 and growth hormone ongoing, and has been studied in the clinical trials. Some of you have done those. I've seen a few faces that really put their best effort into that trial, even on the placebo arm, struggling and getting through to help us get that research and get that drug approved, and it was. And I hope those of you who need it have access to it. It continues to work ongoing for several years in the extension studies. Not everybody should switch to the oral. This is a personal decision to make with your doctor. And one of the benefits is if you're having injection site problems, obviously that would go away. You don't have to get to the center. So if that's a burden for you, which it is for some people, then, that's a benefit. Some people love going and seeing Michelle and Karen every month, and that's like a good thing for them. If you do go on the oral, you can still visit us. It's easier for travel. We had heard from Becky last night about how in the older days she was getting into trouble on the airports because she likes to travel and she had the injections with her. It's faster to titrate IGF-1. I love that because it's so frustrating when we have patients on the long acting and we switch dose and we're looking for that IGF-1 and we have to wait like 3 months and then also wait the 2 weeks that Quest takes to get our IGF-1 levels back. So it's a faster titration, a faster washout if you want to get it out of your system quickly. So all of those are benefits of the oral. The problems are remembering to take a medication twice a day, around the eating issues where you can't eat for a couple of hours after you take it. The long-term tumor control, although it should be exactly the same because octreotide is octreotide and we know it for the injections works, it's the same molecule, but there hasn't been specific studies on the oral looking at what happens to tumor. And we haven't seen the results of studies on combination therapies with orals and other drugs. Pasireotide is a great choice if you are responding, but like not perfectly well controlled with octreotide or lanreotide because it shows just a little bit higher efficacy, as I mentioned, because it has a broader spectrum of what type of somatostatin receptor it binds to. And you can see that almost all patients that respond with the octreotide that also respond to pasireotide with decreases in tumor. So these graphs are each line is a patient and 0 is their starting point of their tumor. And everyone who goes down means their tumor is shrinking. And everyone who goes up means their tumor is increasing. And you can see that most people that are taking this and responding to it have decreases in their tumor and very few have increases. So for those who it works well on both. The problems with pasireotide is the hyperglycemia, which occurs higher than in octreotide. And so you can get into trouble if you have diabetes, or you can even develop diabetes from switching to that drug, which is the downside of it. What about pegvisomant? I know we talked about this in the small group dinner last night, that it's a tricky one because you can't watch growth hormone levels on it if you're taking Somavert, which is pegvisomant, and it's a sub-Q injection that blocks the growth hormone receptor. A really great drug because it doesn't matter what your tumor's doing. You could have any type of tumor, and it's going to work for you because everyone alive has a growth hormone receptor in their body somewhere, and that's how this works. So you can see it kind of like works in everyone if you're on enough of it and you don't watch growth hormone levels because it doesn't decrease them. It actually just decreases IGF-1, and that's the black line going down. The orange line is growth hormone, which oddly enough actually increases when you take this medicine because as the receptor is blocked, it prevents the feedback. That lower IGF-1 helps to lower growth hormone. So when you remove IGF-1 and you're doing a really good job of blocking that, the growth hormone will go up in this drug, as opposed to the others where growth hormone goes down. Luckily, tumor size does not increase with pegvisomant, and there's really very few safety concerns. Some of my patients, particularly women, and I think it's been reported to be very, very low, like 6%, although maybe underreported, that you get little lumps at the site of the injection. I've had a few patients that absolutely have refused to take it because they hate that part of it. But it is fairly rare to have that. And liver abnormalities, we used to worry about them more. It looks quite safe, but I still check those whenever I get a blood test for IGF-1 if somebody's on pegvisomant. So just to summarize, if you haven't achieved normal control and IGF-1 normality after surgery, the first generation somatostatin receptor ligands are appropriate for you to use. These are the long-acting injections, lanreotide and octreotide, or switching to oral octreotide. And you guys really don't even need this little mnemonic that I give to the endocrinologist because they get very confused about like which drugs are which, because I understand like if you're mostly treating diabetes like 99% of your practice, and I'm standing there giving a talk about the one patient that they've seen once, and there's all these medications that they barely remember, they need this. I don't think you guys need this, but you might like it. The audiences really like this, and I am a big fan of coffee. So it's all about coffee, which we have plenty still in the next room. So the bottom line, like your cup of coffee, your regular mug of coffee is like your first generation. It's your basic lanreotide, octreotide, that's your coffee. But you can have the same thing if you prefer it iced. That's your oral octreotide. It's the same thing in a different form, pill instead of an injection. You can switch to pasireotide if you want something a little bit stronger. It's like your espresso. Cabergoline, very light touch for people with elevations of IGF-1 that are less than double normal. That's just a cup of tea. And then pegvisomant, everybody who doesn't respond to these other ones is going to respond to it. It's your cappuccino, everybody likes it. So there you go. And just to remind you, surgery is safe and it's effective for most people to start out their therapy. Most of you have already had your surgery. Raise your hand if you have. And then sometimes people will need a second surgery or be eligible for a second surgery if they have a tumor that's still there in a place that you can still get. And following this talk after lunch, we have like some of the world's best surgeons. Many of you may have been operated on by either Ed Laws or Brooks Swearingen at MGH, Ed Laws at the Brigham. We are now all one, and we have both the Brigham surgeon who is trained by Ed Laws, Tim Smith, coming. He's flying in to do this talk. He's coming in from the Netherlands where he was giving another talk. And he'll be here, and Pamela Jones, who is always doing many acromegaly surgeries every week, and she will be speaking to you about acromegaly, and she was trained by Brooks Swearingen, who may have operated on many of you. It's still a choice for second surgery in some people. Medical therapy, if you're still having elevated IGF-1s and you haven't been completely corrected by surgery. And then what about radiotherapy? You know, it is not, I think we're using it less and less. People are a little scared of the idea of radiation. It is not a terrible idea when it's done right, particularly if you're one of those people that's eligible for a single dose. If you don't have a gigantic tumor left, and it's not close to the optic chiasm, you may be eligible for a single dose. Once you do that, eventually you will probably reach a full remission or cure and will not need medications anymore. So that's good for someone who hates the medication, who's not doing that great on them, or feels that they won't have access to insurance to get it covered ongoing. We're really lucky that we have some future directions, even with some advances in these medical therapies that I've discussed. There's some new kids on the block coming. The two in green highlighting are the ones that are coming very soon. So the monthly injection of octreotide will be hopefully a pen, where instead of coming into the center or giving a big shot, you're just doing a little click of a pen. That will be a great advance. And also a new oral somatostatin receptor agonist, which really looks great. I'll show you the data that is coming probably in September, we expect it, so super soon, which will be 1 pill a day. And then down the line, maybe further along, we might see a long-acting octreotide every 3 months. That's in phase 2 trials, and an antibody that binds the growth hormone receptor. So the mechanism would be like the cappuccino, where it would work for everyone, but that's very early stage development in animals. This is beautiful data from the long-acting octreotide depot pen. So it'd be like the same as the octreotide or lanreotide, but as a pen every 4 weeks, or a very little sub-Q injection that you could easily give to yourself every month. And here is the paltusotine, which is the new pill that will be coming. That is a non-peptide small molecule, very targeted to somatostatin receptor 2. So if you respond to octreotide, you will very likely, almost certainly respond to this. It's in very late stage development. You'll be seeing it soon. Further along are the ones that I mentioned, the long-acting release of octreotide and the one that binds to the growth hormone receptor. Those are further away. We may or may not see it. The DB04126, which is the very long-acting formulation of octreotide, that is in phase 2 trials, in human trials. So we probably will see that. The other one that we don't know because it's been in dogs and rats. It's going to be developed for a combination therapy, probably because they already have animal studies using it as a combination therapy. And now we have, actually, I managed to catch us up. So I have 5 more minutes. I want to show you something that I have not shown to any other audience so far. We have data that is fresh off the press. Chiesi was a sponsor of this study, as well as the Women's Wellness Foundation and our departmental funds. This study was worked on by our former postdoc research fellow, Alon Remba, as well as Karen Liebert, Michelle Adams here in the audience, and Dr. Mascano, who's walking around with the questionnaires. And what we did is we wanted to ask a question, a question that came up from your group and others, which is, are there breakthrough symptoms before the injections when you're on these long-acting somatostatin receptor ligands? And if so, how does that tie in with changes in the levels of IGF-1? So this schematic is showing you that we drew bloods and got surveys in patients on 2 months of a long-acting injection, and we got their bloods right after their shot and then right before the next one was due. And in several different assays, we did see that in the late phase, before the next injection was done, that the IGF-1 did go up and that there was a significant difference, as shown in the little stars here in these two assays, which was a Quest assay here and the German assay that's supposed to be like a gold standard assay. And in both cases, we saw that when your injection was due, the IGF-1 level was in fact truly higher in a prospective study. And then we found as well that symptoms were worse toward the end of the cycle in correlation with that. And the blue here is the total score on the symptom score that you've all probably seen and filled out before, the acromegaly symptom score, where you're looking at swelling and tingling and headaches and sweating and joint pain and fatigue and grading them from 0 to 8. And 8 is the worst, and blue is when you can see the one that goes out the furthest is the one that's rated the worst. And you can see that the worst total score was here at week 4, right before the next shot was due, right when the IGF-1 was starting to peak, and that there was a significant change in the symptoms if you looked at week 4 compared to week 3 or week 2. So basically, summary, symptoms got worse as your shot was about to be done, just like the patients have said for years, but nobody has really shown in the literature so clearly, and that correlated with the IGF-1. So I want to thank the sponsors of this whole day, because it's been really incredible, all of them, and Chiesi, who had helped us with the funding of this study, as well as Alon Remba, who's shown here, who just finished his 2-year postdoc research fellowship, as well as Karen Liebert, who did this study and saw you if you were in this study. Thank you for doing it. Michelle Adams, who also helped, and Dr. Mascano, who's here with us, who kind of helped us get this paper into submission, and we'll hopefully have it published and you'll be able to read about it, and you are the first to see it. Thank you so much for your attention.